Good afternoon, everyone. Thank you for joining us. We are just giving an extra minute or so for people to still come in who may be linking up with us. We appreciate you taking the time to join us today. And like I said, if you just give us an additional minute to ensure that everybody who's in the waiting room can join and can hear us. So as people are joining, thank you for joining us for the technical workshop on medicines access under the National Health Insurance. Our discussion today is mainly going to be based around selection, pricing, and procurement. And there we go. So we've all heard about National Health Insurance and the implementation of the National Health Insurance for over a decade now. And the key principles underlying the idea or the concept around National Health Insurance is to be able to allow access to healthcare irrespective of socioeconomic status. That we have a single fund that has enough in order to be able to effectively meet the health needs of the population, and that we have universal health coverage to overcome the inequities of the past as well. So we have some wonderful speakers with us today. I'm wondering whether you can see me because of the, there we go. Let me just minimize that. There we go. So we have Fatima Hassan from Health Justice Initiative to be able to also chat about their experiences with the NHI bill. Andy Gray from the Discipline of Pharmaceutical Sciences at UKZN is going to be with us to talk about selection mainly within the public sector, but selection, pricing, and procurement within the public sector. And Inez Naidu from Discovery Health is joining us to talk about the private sector issues with National Health Solution. Now, remember, this workshop is not just about the problems, but we are trying to get to solutions and how we can overcome these gaps that have been discovered with the NHI bill in its current form. Sorry, my mouse seems to have been lost. Let me just see if I can do it this way. There we go. So just to give you a brief background, a lot of us know how this has actually come about, but we started very early in terms of medicines, policies, and legislation affecting the goal and the move towards national health insurance. And you can see that actually the National Health Insurance, even though the bill came out in 2019, they have been the green paper, the two white papers, changes to the Medicines and Related Substances Act over the time. There have been changes or introductions of Competition Act, Public Finance Management Act, National Development Plans over time. And more recently, there have been the stakeholder participation or comments to the Portfolio Committee between 2021 and 2022. In 2022, they were concluded, and the Portfolio Committee then began their deliberations. Most recently, those of you that are subscribing to Drug Info would have noticed that there was an amendment bill that was published by the Portfolio Committee. It still has to be considered by the National Assembly and the National Council of Provinces as well. So this is not the final review by any means. Okay, so I'm going to stop there at the moment as an introduction and stop sharing my screen. Oops, sorry. I have to maximize my window first. I've stopped shared, and I'm going to hand over to Fatima Hassan. Fatima, give a brief introduction of yourself as well to people who might not know you, and then I'll hand over to you for your presentation.
Thanks. So I've just started load shedding and switching to another computer. So can you just do a thumbs up if you can see the screen? Yeah, great. So just a very short introduction, and thanks to Fatima and Andrew Andy and Ines for being part of this workshop. And as Fatima said, we're really concerned about the future and trajectory of medicine access in South Africa, both in the public and private health sector, for a number of reasons. And this is why, as Health Justice Initiative, which I direct, and we've been working on this issue with my colleague Marlies Richter, who's here on the school. She's a senior researcher at HAI, to look at some of the questions that we have basically asked government as well as Parliament in relation to Bill A. And as Fatima's mentioned in the last week, there's now Bill B. We're going to have to go through 60 pages line by line to see what the actual amendments were. So just a bit of context on that. There's a number of processes unfolding in Parliament. We've just heard this morning that we believe that NHIB bill is actually going to be debated in Parliament on the 13th of June. So I think there is a very critical time period within which a lot of decisions are going to be made that's going to affect people both who are users of the public and private health sectors, but also I think particularly people who are migrants, asylum seekers, and what the bill is now referring to as foreign nationals. So there's going to be a huge change in the way in which people are going to not just access health services, but also in the way in which they're going to be able to access medicines. And that is the reason HAI has been working on this issue, which is why we have concerns, which is why while like many others and everybody has said this publicly, they support the aims of universal health coverage, we are concerned that there are several gaps in the bill and several issues that can't just be dealt with regulations. And, we had previously last year when we released our paper on the NHI bill version A, which you can find using this link, we basically had called on government to set up a multidisciplinary task team, because honestly, we don't believe that this is something that can just be located within the Ministry of Health or Department of Health, because it's going to take a number of different technical stakeholders to actually figure out a robust and sound system for medicine access going forward. So the 17 questions that we've raised mainly relate to medicine selection, pricing, and procurement, but it also relates to exclusions from the bill. It relates to the ambit of different government departments, as well as the role, for example, of the Competition Commission in price regulation and price setting under the NHI fund. And you can find the questions using that link, and we'll add that to the chat as well. And unfortunately, just my last point, Fatima, on this before I then hand over to the technical part of this conversation with Andy and Ines. We asked 17 questions around version A, and based on the deliberations of Parliament in the last few weeks and the recent adoption of version B, which, like I said, is going to be debated in the next 2 weeks. Of the 17 questions, there's still many that have not been answered or not satisfactorily dealt with. There's 1 or 2 that actually have been addressed or dealt with. But HAI was formed at a time after the submissions for the public were open to comment, and Parliament didn't allow us to make a formal submission. So this is why we had to raise these 17 questions publicly. But there's only 2 that have really been addressed. So we're really concerned that many of the questions that we've raised, in the interest of all people living in South Africa to be able to access the best that science has to offer going forward in this country post-COVID, during a time of recession, during a time of increasing corruption, not just in health services, but in other services, remains critical. And unfortunately, we believe that we are currently in a situation where the politics of NHI has become a partisan issue between opposition parties and the ruling party. And we really are concerned that the people who should be listening to the warning signs that we are sort of signaling and ringing around the future of medicine access are not willing to engage on this critical issue. So this is why we're having this series of workshops where HAI is partnering with UKZN, and like Fatima said, is to offer suggestions and solutions as well going forward, drawing on a range of different stakeholders. And hopefully our policymakers will actually listen to that going forward. Thank you.
Thank you so much, Fatima, for setting that scene as well. We have opened up this discussion to everyone so that there is a range of stakeholders in this particular environment or platform, talking about solutions and talking about issues in that regard. To talk mainly about selection, procurement and pricing in the public sector, I'm going to hand over to a colleague of mine from the University of KwaZulu-Natal, who's well known to all of you, if not most of you, Andy Gray. Andy, do you want to do a brief introduction? Because it would take the entire webinar to cover everything that you do. And then do your and then take over for your presentation, please. Thank you.
Thanks, Fatima, and good afternoon, everyone. So I'm a senior lecturer in pharmacology at UKZN, but I've also got a number of years of engagement in the regulatory space as a member of the Medicines Control Council and now technical advisory committees to SAHPRA. And I also serve on the National Essential Medicines List Committee. So that does the selection in the public sector. So just to give you a sense of why we use these terms in the beginning, let me explain a classical view of the pharmaceutical management cycle. The idea that we select medicines, we choose medicines from all of the medicines that are available on the market, and we usually refer to those as being essential medicines. Those are then bought, so they're procured, brought into a health system, distributed to the places where they need to be used, either in inpatients or in outpatients, and they then get used by patients and caregivers. And that feeds back into a reconsideration of whether those medicines are in fact the right ones. New evidence might come along. All of this has management support underpinning it, and it works within a policy and legal framework. But I want to just contrast quickly the current arrangements in the public and the private sector. So in the public sector, the selection process is driven by the National Essential Medicines List Committee, or NEMLAC. NEMLAC comes up with a list of standard treatment guidelines for different levels of care, so primary health care, in-hospital care, and tertiary and quaternary care. And from those standard treatment guidelines, we extract a list of medicines. That becomes the essential medicines list. Those are procured on the basis of a state tender. So a tender is called for all suppliers of that particular medicine, and that is not only the active ingredient, but in a particular dosage form and strength for administration by a particular route of administration, are called for, and on the basis of price and consideration of local content, those awards are given for 2 to 3 year periods. Usually a single supplier wins the tender, so it's a winner take all. However, in cases where there is a concern over security of supply, those tenders can be split. So for example, for the antiretrovirals, 8 companies have been awarded the tender to supply the first line fixed dose combination used in adults with HIV. But importantly, the state buys against that tender. It either buys for delivery to a depot, and there are 10 of those, 2 in the Eastern Cape, 1 in each of the other provinces, or for direct delivery to a health facility. The South African National Defence Force and the Department of Correctional Services also buy against the same tender, and they get deliveries directly into their facilities. The private sector is completely different. 3 to 5 benefit options each. And those formulary, now there might be shared formularies between options or between medical schemes, but the formularies take into account what the Council for Medical Schemes says has to be provided. So those are the prescribed minimum benefit algorithms for the chronic disease list. However, the schemes do not buy, they reimburse. They pay for something which has been bought by the providers be that a hospital or a pharmacy or a dispensing practitioner, and those providers buy from wholesalers at the single exit price. That's the factory gate price, including the logistics fee. And the schemes then reimburse on the basis of claims made by service providers. So how does selection get described in the white papers? I want to contrast the 2015, 2017, and then the final B version of the bill. I'm not going to worry about the draft bill or the A version. So the first structure that is mentioned in the white paper is the NHI Benefits Advisory Committee. It's meant to decide what will be covered in terms of services as well as medicines, medical devices. So the range of services has to be reviewed by this committee based on best available evidence on cost effectiveness, efficacy, and what's called health technology assessment. And then an inventory of medicines, medical devices will be updated by that benefits advisory committee. There's slight differences in the 2017 NHI policy document, which some people refer to as a second white paper. This now says the NHI Benefits Advisory Committee will be supported by various committees to make evidence-based recommendations. And it references two WHO documents on priority setting and health technology assessment. And again, it says this range of services would be regularly reviewed using the best available evidence. Also in 2017, there was a document published that identified structures that needed to be established as interim bodies before NHI came into effect. Two of those were ministerial advisory committees on healthcare benefits for NHI and on health technology assessment for NHI. So the first would be a precursor to the Benefits Advisory Committee. The second was indicated as a precursor to an HTA agency. So what is this? In other countries, we've got agencies like that. The National Institute for Clinical Excellence in the United Kingdom, NICE, is an example of an HTA agency. IGWIG in Germany is similar. Importantly, there were some caveats to this role. And there was a statement that this Ministerial Advisory Committee on Healthcare Benefits would not replace or duplicate the functions and responsibilities of the expert review committees established to develop the essential medicines list. So we see a bit of ambivalence about, okay, we've got something running at the moment, the essential medicines list process. This will not replace it. And there's also a statement that it will not replace or duplicate the functions and responsibilities of the Committee on Health Technology Assessment. However, these are not mutually exclusive. They're meant to collaborate with one another. So who's on the Ministerial Advisory Committee on Healthcare Benefits? It was meant to be appointed with representatives predominantly of stakeholders. You'll see their government representatives, academic representatives, professional councils, the colleges of medicines, and then there are people who've got particular expertise, private hospital management, actuarial experts, academics and research. And this committee was meant to report to the National Health Council via the NHC Technical Advisory Committee, or NHC Tech. However, the NHC has no private sector involvement. It's really more involved in the intergovernmental relations between the national department and the provinces. Those structures are not in place. The B version of the bill, which is what will now go to the National Assembly for pretty much a rubber stamp, will go from there to the National Council of Provinces. The NCOP will have to get a mandate from each of the provinces for the vote on the B version. And that means that their legislatures will have to debate the B version, and they might, in fact, call for public hearings in the provinces before giving a mandate to their NCOP delegation. And they add additional delegates with technical expertise to those already sitting in the NCOP. If there is a difference of opinion between the NCOP and the National Assembly, then a rapprochement has to be sought, and that has to be reviewed, a new version agreed upon. If the National Assembly wishes to override the NCOP, it needs a 2/3 majority, which is unlikely at the moment, as we've seen with other bills. So in the bill, there is provision for the fund to create a benefits advisory committee. It's going to be one of the advisory committees to the fund, but set up by the minister. But if you look at what it's meant to do, it must devise detailed and cost-effective treatment guidelines that take into account the emergence of new technologies. So it looks like this body actually has not only a broad benefit decision, but in fact, a quite detailed responsibility for making guidelines. There's also the creation of a health products procurement unit. This used to be in the early version of the bill called the Office of Health Products Procurement. It's now downgraded somewhat to a unit. But if you look at its obligations, the Health Products Procurement Unit must determine the selection of health-related products to be procured. So is this just a procurement step, or is this a selection step in the form of writing guidelines? That is the job that's already been given to another committee. It's meant to support the Benefits Advisory Committee in the development and maintenance of what's been called the formulary. The formulary is the essential medicines list and the essential equipment list. By equipment, we don't mean major equipment only, but medical devices and diagnostics. And there's talk of this being done in consultation with the National Health Council and the fund, which also adds another layer of complexity. But here comes the real important bit. An accredited health service provider and health establishment must procure according to the formulary, and suppliers listed in the formulary must deliver directly to accredited and contracted health service providers and health establishments. This is very different from the way in which, at the moment, the provinces procure their medicines and distribute via their depots. I don't expect you to try to work out this diagram, but I wanted to draw your attention to a paper that was published last year by Wilkinson et al. In the International Journal of Technology Assessment in Healthcare. And it pointed to the fact that elements of health technology assessment are used already by a whole variety of institutions in both the public and the private sector. So in the way in which medical schemes engage with professional societies in coming up with their own clinical protocols, in the way in which NEMLAC engages with the evidence and makes standard treatment guidelines that inform state tender, elements of health technology assessment are already being used. And if one of the basic intents of NHI is to enable the fund to be a strategic purchaser, then selection has to be done on the basis of the best available evidence. But it appears that what we are talking about is in fact reimbursement, not procurement in the sense of buying stock and having it distributed through the depots to health facilities. There's more of a supply for those that are used in those facilities, but it doesn't look like this is going to be the same as the state tender. Now, we mentioned the single exit price and the state tender price. Those are completely separate. And the single exit price currently is defined as the price paid by anyone other than the state. In other words, the whole of the private sector or non-governmental organizations not within the state. And that is going to have to change. There was in the A version the definition of the single exit price to become the fund or anyone else. That has now been removed. That revision of the SEP definition is no longer in this bill, which means that we are left with a definition that says the private sector pays one price and the state pays another price, and NH. So there are serious questions that need to be asked about how.
Andy,
Prices.
we're losing you. You're freezing a bit. Could you repeat that last part, please? Thanks.
So what I'm saying is that
Forward, we have to be.
And you're fading in and out, so I'm not too sure whether you're moving or whether it's the mic.
Busy rotating at the moment, so that's why. The main thing is that under NHI.
Sorry, Andy, we can't hear you.
And its price and its single exit price still has to be resolved, and merely deleting that change to the Medicines Act does not deal with the problem. It stops a new problem being created, but it leaves us with an existing pricing structure that assumes that there is an absolute separation between the public and the private sectors. Thanks, everyone.
Thanks, Andy. So if I can just summarize your last bit, because we kind of lost you there. So I don't know if you want to say that there's still an issue in terms of pricing structures under NHI, because at the moment what's not addressed is the separation of pricing between public and private sector. There's still the SEP and there might be an NHI price as well. Am I right?
So we don't know how the NHI price would be determined. At the moment, the assumption is that the two prices are very different. And since the NHI involves private sector providers supplying products and services for the fund, which price is going to be charged? It can't be either the state tender price or the SEP. It must be something else. And it's unclear now in the bill what that something else will be.
Thank you, Andy. I appreciate it. I apologize. We kind of lost you in between. For our participants, we had asked Department of Health to be with us as speakers. Unfortunately, they could not make it. I'm hoping that some of them are here as participants and can respond to some of the issues. But that's why we had Andy to cover this particular section. I'd like to now hand over to Inez. Inez, also give us a brief introduction to yourself. I think for the purposes of bandwidth, I am going to switch off my video in the interim so that just you are visible, and you will be addressing the issues I think that the private sector is considering or facing. Thanks.
Thanks, Fatima. Good morning, everyone. Or good afternoon. Now it's past 12. My name is Inez Naidu. I'm a pharmacist. I work for Discovery Health. My role is to manage the medicines unit, which embraces all things from benefit design and strategy and budgets to engaging with the pharmaceutical sector and multiple stakeholders in the industry, including healthcare providers and regulatory authorities. So I have been at Discovery for 20 years now, so it's extensive experience. Let me try and share my screen to share a brief presentation. Can you see my screen?
Not yet, Inez.
And can you just let me know when you can?
Not yet. I'm not too sure if you want to email me in the interim and I can share on your behalf as well.
I think that might be a better idea. Just going to quickly do that. Apologies. Can you still see me? You can't see my screen yet, no. So I'm just going to quickly email this to you.
It depends, because sometimes if you're working off two screens, then it doesn't show up on Zoom. It prefers you to work with one screen.
Okay, I'm just going to quickly attach it. I think this should be fine.
Okay.
It's on its way to you, Fatima. Apologies.
No problem. Hopefully it'll be here quickly and I can open it and share it on your behalf. I don't know if you want to start and chatting a little bit in the interim while we're waiting for the slides to come through.
So I could. I think I'm just going to give you a brief introduction of what we experience in the private sector, a brief introduction of Discovery. What we do is we cover approximately 3.7 million to 3.8 million lives under administration. That is a 42% market share of the private sector. The Discovery Health Medical Scheme alone is an open medical scheme, so that's open enrollment. And the lives under administration, there is roughly 2.7 million, which in itself is a third of the market just on its own. So the experience we draw is from our size and scale and over 30 years of being in the market and engaging with the respective stakeholders. I think Andy's given a fairly good introduction to the private sector, so mine will be very brief. When Fatima draws up the slides. Is it still not on its way to you, Fatima?
Sorry, not received as yet, but I'm looking at the inbox. So if you want to continue, as soon as it's there, I'll open it.
Yeah, I think seeing as I've got the presentation, I think I can maybe talk through it a bit. So I think with the two-tiered structure, we see that the private healthcare sector represents a marginal amount of lives, roughly about 9 million. The Council for Medical Schemes basically noted in their last report ending March 2022 that the private sector covers roughly 8.95 insured lives, and the public sector roughly about over 51 million. So huge disparity between who gets access to private healthcare and who uses the public healthcare system. That said, there are more people that use the private healthcare system than are actually insured. So it's thought that about 30% roughly of South Africans use the private healthcare system, even though they are not privately insured. In terms of regulation, the private healthcare sector is highly regulated. We manage mainly by the Medical Schemes Act and by the Medicines Act. And the Medical Schemes Act basically tells you about the Council for Medical Schemes as a governance body and describing prescribed minimum benefits as mandatory cover. And in the Medicines Act, we basically have the pricing committee from the National Department of Health managing medicine pricing, as it were. On the public sector side, there's the essential medicine list, as Andy mentioned, standard treatment guidelines, and a tender pricing system, unlike ours in the private sector. So looking at access, the private sector, if you look at infrastructure and access is extensive. It's an established supply chain and a well-established infrastructure. It's got comprehensive health coverage and comprehensive administrative capacity for electronic platforms. It also has extensive data analytics capacity. If you're looking at the public sector, less so robust on the supply chain, and access, limited health coverage, and it's also limited data analytics. On the cost of the care, looking at private sector, it's expensive. Co-payments do apply based on affordability. But in terms of the mandatory cover like PMBs, it's unadjudicated and a growing cost. The high-cost novelty medicines that we have in the private sector that you practically do not see in the public sector is the new driver of healthcare inflation for medicines. And it is an inflationary risk because it's a growing number of products and a growing utilization in that sector. It roughly takes up about 35% of the total risk portion healthcare spend in the private healthcare sector, well, for Discovery anyway. In public health, you've got predominantly free access to medicines, We believe that the medicine profits are cross-subsidized, and I say medicine profits, not prices. The profits are cross-subsidized heavily by the private sector, and economies of scale in terms of procurement does give the public sector an advantage for better price efficiency. But if you look at the two prices, the single exit price and the public price, there's a huge difference between the two, sometimes up to 4,000% differential. And it's not necessarily the same active ingredients, the same product from the same supplier. So trying to understand how you merge the two and what is an affordable and realistic price means you've got to unpack the prices in both sectors, look at the utilization, look at the sector-wide capacity, and try and understand what is a reasonable price. Even if you did a national benchmarking of generics, prices range from 0 to 200% for the same active ingredient strength and form. So lots more needs to be done in trying to solution what an affordable and fair price is. Fatima, sorry, do you still not have the slides?
I'm showing them on the screen at the moment. Can you see them and tell me where I should be?
Okay, one up, please. Two up again. Another. I think you're going in the opposite direction. We can just start with the second slide, Fatima.
Okay, just let me go up. Is that the one you want?
This is the one I think I've just spoken through, and
Okay.
then we can go to the next one. So this slide basically speaks to some of the key challenges that we're experiencing in the private sector. So the intention of the legislation was good. It intended to provide more affordable access to medicines than the system prior to 2004. There was discounting, differential pricing, and people didn't really know what they could pay for a medicine using different suppliers, or basically points of access like pharmacies and doctors. So the legislation was introduced in 2004. There was a brief adjudication, and from 2007 onwards, there's been compounded increases of medicines, and the pricing committee at the National Department of Health caps the extent that you can increase the price year on year. However, the transparent pricing system extends beyond South Africa onto the global market. And what the pharmaceutical companies have essentially said to us is that because the rest of the market or the global market looks at the price, I can't really give South Africa a good price, especially for a patent protected medicine, because then it's going to be subject to international price benchmarking. And I can't have that. I discount in other markets, but it's not allowed here. Technically, it is allowed here. But if you keep the price transparent to within South Africa only, then apparently we could get these far more efficient prices. So that's the main discussion that the private sector and Discovery Health is having with the government in the pricing committee at the moment, to figure out how the price can be transparent only within South Africa, still ensure that all the patients or consumers that use the price still have full access to what it is, and the standard same access. So there should not be differential pricing. There should be discounting and efficient pricing, but accessible to everybody in the private sector at the same price, and managed by the custodians of price files. The Medicine Act price efficiencies, which is another problem, is that they do exist in the Medicine Act, but none of these efficiencies have been deployed. From international price benchmarking to rendering an SEP as unaffordable and or any of the health technology assessments that can be done. When it comes to Regulation 9 as well, you can take an increase over and above the standard regulation annual increase, Regulation 8 annual increase, and this is not adjudicated into the quantum and what happens thereafter. So the impact on the private sector over the last 18 years has been phenomenal. We try as best we can to manage some of these challenges, but it gets complicated when you have to pay for prescribed minimum benefits, especially for low-cost plans, where it becomes exceedingly more expensive. There are exemptions that can be applied in terms of Section 36 of the Medicines Act, and that is now being explored as a way to kind of circumvent the global transparent pricing while that aspect is being addressed. So if there's no other way within the existing framework, we may need to use the Section 36 exemption for better pricing for SA. Can you change the next slide, Fatima? Okay, looking at how private healthcare manages medicines, it is a robust administration, communication and risk management capability and platform. We start on the left with benefit design. So you choose a health plan, and it's called a benefit plan type. And then you see what you have to contribute every month for that plan, what the network rules are, what co-payments apply, and what waiting periods will apply if you disclose what conditions you have. Then we give you a scope of cover, tell you what conditions are covered, and then we apply strict clinical protocols, clinical entry criteria based on best evidence and guidelines. And we have to adhere to the PMB regulations using the treatment algorithms. And then there's a pre-authorization application process. So you first have to apply for a benefit like HIV, oncology, and chronics. That's the CDL PMB conditions. Certain high-cost meds, including in hospital, also require pre-authorization. So there's an entry access point. Once you get in, then there's strategic risk management adjudication that happens. One of the cornerstones that underpin all risk management in medicines is the product file. It's a therapeutic product price file that has every single medicine that is available for sale in the private sector, clinically coded to identify the active ingredient, the medicine class, whether or not it's a generic, whether or not it's a biologic, and we do this in-house at Discovery Health. We even developed our own generic coding system to pick out the originator to the generic, to the biosimilar, to the biologic, and we identify novel medicines using profiling tools from the WHO. When you claim a product from us, we use this therapeutic file to basically design benefits like formularies and reference pricing and limits and acute co-payment tiers in the acute environment. And we use this price file to adjudicate on price and to adjudicate on benefit based on a clinical category of a medicine. Over and above that, for new technology, we have a health technology assessment team and unit that uses clinical evidence and price efficiency and affordability to evaluate new medicines on the market. That said, that doesn't mean we always get the best price, because you can get a better price than the launch price of a medicine, but not necessarily a price that is affordable to all benefit plan types. And we find that we restrict access to expensive and new technology to the higher benefit plan types, which represents only about 10% of the membership. In addition, there is an ongoing electronic adjudication of medicine claims system that we have that adjudicates every product on the basis of price, what is the maximum quantity that you can take based on the package insert, how frequently you can take chronic medicine, example, not more than once a month, what is age appropriate, gender appropriate, and prescriber appropriate rules, amongst others. So the adjudication platform is electronic, it's robust, and it's based on extensive clinically coded data, as well as priced information that comes from the Department of Health directly and from the manufacturers where the price is not regulated. This includes all medicines and surgicals. Looking at stakeholders, how do we deal with stakeholders and who are stakeholders? So provider contracting is basically how the private sector or the health insurance company deals with doctors, with pharmacies, with hospitals. We have contracted networks with them. When it comes to pharmacies, our contracted networks cover 95% of all medicine claims coming into the business. And these contracts are negotiated on the basis of the price for a service and the type of service and the adherence to the local protocols that we have in the business. Pharmaceutical price negotiation is one of our key strategies in the business. It is 50% of what I do at Discovery Health, and I particularly focus on high-cost novelty medicines. These things support our formulary and reference pricing strategy, our benefit design, how we pay for new technology, and we have made headway to the tune of billions over the last 10 years in terms of pharma price negotiation. That said, knowing that we don't really have the most efficient pricing system, there is a lot more that can still be done with efficient pricing in medicines. It is the patent expired products and the free market generic price competition that gives us a lot of the price negotiation, especially for the formularies and the PMBs. But with high cost novelty medicine, price negotiation is extremely difficult. When we look at affordable medicine stakeholder engagements, we talk about the engagements with the National Department of Health that is extensive. We work routinely with the Council for Medical Schemes. We even work with the Competitions Commission on excessive pricing investigations into medicines. We work with patient advocacy groups, and key opinion leaders like key medical societies. In terms of member communication, there is nothing that we do that isn't extensively communicated to the member. So they know exactly what is covered. They get letters on any benefit change. There's a call center that's freely available to answer all your questions. We help them with medicine delivery partners. There's claim statements to tell you exactly what you claimed and how you covered. And there's a website and an interactive app that helps you navigate the entire system. So end to end, we have a structured environment, we have solid risk management strategies, and we have a robust stakeholder engagement strategy. Next slide, Fatima. So this is a sketch of how we envision the NHI framework to look. We're just imagining that this is how it would look, but it's not really 100% guaranteed. As you know, there's lots that still needs to be approved. So we're looking at a tiered structure where you have the NHI primary healthcare basic package, then a primary healthcare top-up. We assume that it will include some over-the-counter medicines, then some secondary, tertiary, and quaternary specialized healthcare that can be provided. So in terms of the brown bars or the brown colored blocks, these are what we think the private sector will still have to do. And we're hoping that in the bottom tier on the NHI platform and primary healthcare, that there would still be public-private partnerships and not just 100% contracting for NHI, because there is a lot that the private sector can offer in terms of administration and claims adjudication, and also in terms of the data that we have that shows you where money goes and where money flows, and where we can add efficiency using data as far back as 20 years ago. So that's how extensive the data is and how robust and detailed it is. In terms of the right-hand side, the value add services, these are things that medical schemes or medical aids already offer, or medical aid administrators. We provide allied health services, wellness, screening, lifestyle and vitality, gap cover for what your medical aid doesn't cover, and extensive data informatics over and above what is covered for every single plan type. And all of this is underpinned, like I said, by electronic platforms and the electronic health record. So this is important to understand in terms of what you choose for the different buckets of care, because the cost is extremely different. If you completely take the bottom tier out of the private sector, it basically wouldn't survive. It would be largely unaffordable. If you use only the expensive non-primary care, non-PMB medication with higher prices that cannot really be justified or are not even adjudicated, it is a situation where we have right now where the healthy subsidize the sick. And if you're going to take a huge portion of it and only leave the most expensive portion in the private healthcare, that is going to be a concern in terms of sustainability of anything that is not basically covered as part of NHI. Fatima, the last slide. This is just a slide showing you how alternative reimbursement works. Alternative reimbursement is alternative to fee-for-service. So you send in a bill and we pay it. That's fee-for-service. Alternative to fee-for-service is maybe a mechanism called capitation. Capitation is where you have providers that take care of a group of patients and you pay them a fixed amount per person on a regular basis for a defined set of services. And you basically get this amount every single month, whether you provide those services or not. So it is a potential efficient way to manage cost and care, provided that you have all these elements that I've put out there on the slide. So you define the scope of cover very clearly, which drugs, which conditions, which medicine classes, how often do you take it, how much can you take? Because it can't be like a defined amount of money and an undefined classes of drugs and how often a member wants to take it or a beneficiary wants to take it. The capitation fee, it's got to be a fair price relative to the utilization that you're expecting, and there has to be a stop loss or a profit cap. So in other words, a stop loss means you can incur 10% loss in the first month, but not so much on the second or the third month. And eventually the business has to be sustainable with some losses and gains over the period. But if there's a profit cap, you're not supposed to be basically getting an advantage over a capitation fee where you're underservicing and making money out of patients and the healthcare provided is not robust. So for you to make sure that all of this happens correctly, you need to have detailed line item data of what services were provided at what cost per patient for you to analyze whether a capitation system is working or not. There are things also that are called carve-outs. So in other words, you say, this is my basic package, and this is a carve-out, so it's not contracted in. But when you have something like that, who pays for it and under what system? So we still need to have that clarified. In terms of your claims profile, there's, when you look at volume and max weighted cost impact, all of this has to be taken into consideration when you determine what type of fee that you pay for a capitation amount per patient. Critical mass is also very important at the bottom end and at the top end. If you have, for example, 1,000 patients per group practice, you can't have 20,000 patients for the same group practice, but it is impossible for that practice to treat as many patients efficiently within the system. So there's got to be a minimum survival for the capitation and a maximum for it to be efficient. And like I said, the electronic health platforms must underpin everything that you do. You have to monitor everything, and clinical coding is absolutely critical for you to understand exactly what it is you're paying for and how it's inflating in cost and utilization. And the last slide, Fatima. I think this is just in summation that we do think stakeholder dialogue is critically important, which is why we are participating in this discussion. We think that it needs to be sector-wide and include technical experts on access and cost. We strongly believe that public-private partnerships need to exist in rolling out NHI so that we can leverage off the existing infrastructure in the private sector plus the expertise. And it would be ideal to explore NHI in a phased approach to measure and monitor the impact to make sure that people are taken care of the way they are intended to right from the very start. Thanks, Fatima. That's the presentation.
Thank you so much, Inez. I really appreciate that. And I think that in terms of what I've heard between the two presentations and what Fatima's done as an overview, it's basically about the fact that the devil is in the details, and the details are missing in this bill. It talks about principles, it talks about structures, but there's really not much that's there about the actual methods of implementation or that sort of thing. So I think that what I will ask both you and Andy before I go, and I can see there's questions in the chat and ask the others that are participating, is that what I found useful in both is that there are elements in the public and private sector at the moment that deal with some sort of transparency. So, Andy, the EML is up on the master catalog as well as the non-EML. The tender process and the documents are up. We have issues with the MPR database being available or not being available, and those are the SEP prices. And Inez, you've mentioned that the private sector with the schemes have a lot of electronic databases that go into a lot of detail that have developed over time that can capture the information, but it's also not that transparent to everybody else. It's held in-house. So one of the questions is that, how do we make things going into NHI a little bit more transparent and accountable to people? But then who develops these databases? Who owns it? I think that there's also this mismatch between sort of saying the private sector is just about medical schemes and beneficiaries and the medical rates that they charge, whereas you actually have an infrastructure that's not being tapped into. So I'm going to leave that open and ask people, Andy, I don't know if you want to address some of this, and then Inez, and then ask people what they think would be proper solutions to this kind of database development, this kind of accountability and transparency issues as a first step into the questions moving towards NHI. Andy?
Thanks, Fatima. So let me start by saying that what I described was two systems that have some touch points, but are really in parallel at the moment. And yes, there are some uninsured patients who seek care in the private sector, but it's usually for acute conditions which they, for example, can go to a dispensing practitioner or a pharmacy for. What we are going to see is the introduction of a third element, which has to be new, but has to coexist at least for a decade or more with the two existing systems. So the benefits chosen by NHI will never cover everything to begin with, which means that some things will have to stay in the public sector and some things will have to stay in the private sector. And it's only once the minister has declared NHI to be fully implemented, and what that quite means, we don't know. At that point, there will be a restriction on what medical schemes can do. So initially, I anticipate that medical schemes will do a lot of overlap with what is available under NHI. And I also suspect that the public sector will have to do a lot of sophisticated secondary and tertiary level care, even though it might have NHI funding for the majority of its primary care provision. But we'll have three systems running simultaneously. How will we have selection? One is about a winner-take-all selection of perhaps one product that's going to be used, and the other is about a reimbursement level. Will NHI be closer to the public sector or closer to the private sector? I think it has to move closer to a reimbursement and private sector pricing provision. But then we need a lot more than just evidence to back HTA. HTA is only the beginning of the process. It tells you about the quality of the evidence and the backing for the benefits and harms. The value that you attach to those technologies and the negotiation process to get a price is something that I think is entirely obscure at the moment for NHI. And the SEP provision doesn't work for it, and the state tender doesn't work for it either. It has to be something of its own. Thanks.
And also, Andy, we talk about HTA like it's something that's already existing, embedded and available, but actually there is no national guidance that has been adopted. There have been draft documents that have gone about, but not actually been adopted.
Correct, correct. And of course, we've got to deal with the problems of transparency. If this is subject to the PFMA and this 3A entity is procuring, then that has to be transparent in terms of the Constitution, because that is still state procurement. And we've heard from Inez some of the challenges that industry claims around transparency, and especially with external reference pricing. But also, we don't want to go the route that NICE has gone of signing secret deals, where we get a medicine that is provided within the national health system, but the price is somehow kept confidential. And I don't think that is helpful for the rest of the world either.
So Inez, I know there's questions addressed to you specifically in the chat, which I think you can also do, but I also want to just ask you about what I raised about this issue of the medical schemes having experience that's not being tapped into, but also about issues of transparency thereafter that we are raising.
Thanks, Fatima. I think the information coming from medical schemes is not necessarily unique. If you think about clinical coding, this is WHO clinical coding standards. Anyone can adopt those protocols and code the medicines that we have. Lots and lots of organizations in the private sector have done so. Other schemes, Medicredit. The government has also got clinical coding in terms of the essential medicine list, but it's not necessarily so robust to say that you're using the most, let you say, the lowest form of coding, in other words, specific coding for the current applicable year. There is no identification of generic medicines versus others to be of service to the public, to help them choose if you are going to display these medicines. And there is no special regulation of specialized medicines. So in other words, a medicine is a medicine, is a medicine. If you look at the States and the UK, there is a different kind of handling of orphan drugs and specialized medicines, priority registration, different pricing mechanisms. None of that exists in SA, and there's lots of learnings that we can have, not just from the private sector, but also from international markets struggling with high-cost novelty medicines, as well as alternate reimbursement mechanisms that would follow on after you make sure that the price is correct for the South African market. In terms of transparency, I do think we must have transparency within South Africa, but I really don't think we must have global transparency. I don't understand the need for that to help South Africans. I don't think I ever did. So that's important. I don't think that anything we do in the private sector isn't something that a government regulatory body can't do in terms of therapeutic product price files. If we can maintain it, anyone can maintain it because there's guidelines. We maintain it on the basis of guidelines. If you look at the active ingredient strength and form as a pharmacist, I just put a random coding system together with a number and then linked everything with the same active ingredient strength and form. Any pharmacist can do that as part of their professional capacity. So it is something that I do think must be owned by the regulator and not necessarily outsourced to the private sector, because there must be international standards that you adhere to and national guidelines that you must adhere to, and that must be owned by the system.
Thanks, Inez. I think that what I was trying to get to as well is that there's existing kind of structures and things that are in place that could be combined that makes it faster rather than reinventing the wheel. I mean, there is computer files out there that have all of the medicines that are listed in the country already kind of coded in some way. And I know that BHF has started doing these as EML coding versus non-EML coding. There's a way to bring it as NHI funded or not NHI funded. So I guess I'm getting to that point about trying to use existing structures to gain efficiencies rather than having to make the same mistakes all over again. And I'll come back to what you said about global transparency, is that the WHO at the moment is also talking about global transparency, maybe for those that are doing the decision making and not necessarily to the public, but that's a discussion altogether. I want to get onto something else. I will say that if you do want to say something and not type something, please raise your hand so that I can then ask you to talk. Feel free to be able to just sort of raise your hand and I'll have you make your comments or your suggestions. I do want to go back to something. Sorry, Fatima, do you want to say something before I pick on someone and something that was on the chat?
Yeah, no, just to say that I think the conversation is even more concerning because, you know, Andy's point about having 3 systems over the next 10 to 20 years, it's one of the questions we raise about when will the minister determine that it's fully implemented to be able to incorporate, you know, all the private sector lives into one single NHI fund, is that this is going to have a severe impact on poor patients and patients who have to use the public health system, and what the bill is calling foreign nationals, which sometimes fluctuate between migrants and asylum seekers. So, you know, there's a real concern around. I don't know if anybody else is having like major trepidation, because if this bill is passed even this year, the impact on poor patients to be able to access what you're calling high novelty medicines, what we call life-saving interventions, in the absence of a proper pricing system and no global transparency. And global transparency is something that we support. We want benchmarking. Those regulations have not been finalized. In many cases, we're paying more for medicines, both in the public and private sector, than than what other middle-income countries are paying. And I think COVID showed that. So I think just a real concern for patients who are particularly dependent on the public health sector, living with HIV, TB, cancer, who need access to the best that science has to offer. And I'm just not, maybe Andy can come in here. I'm just not seeing how, in a climate that we're in economically, where government is saying that they can't even purchase Paxlovid, that they don't even have money for that, how are we going to be making decisions based on what the best evidence is given the real fiscal constraints, and that is going to have a severe impact on patients. And so that's, you know, one of the arguments we've made in our paper is that what you're actually going to be doing is perpetuating the current system of the haves and the have-nots. And that's where you can access some better medicines through better benefit plans in the private sector, but you won't be able to do that through the state or the NHI. Thanks.
Thanks, Fatima. Just a quick response to that. The benefit expansion is likely to be slow. So in some of the phase approach descriptions, and they vary from the original white paper to the 2017 version, and I really worry about putting deadlines and stepwise processes into
Exactly.
legislation. I think that's a bad legislative drafting option. We always see a focus initially on maternal and child care, some sort of basic primary health care, and you're absolutely right. If that expansion of the NHI basket is very protracted, then those, for example, with cancer are going to be dependent on the existing public sector funding, which is likely to be even smaller than before. If those secondary and tertiary hospitals are transferred from the provinces to the national department, will the national department be able to get that level of funding out of the fiscus? We hope it would be a bit more comparable between provinces. If it's a national provision, fiscal federalism wouldn't apply. But it's going to be very different for a decade or more to what is available in the private sector. And in the private sector, the benefit option scales are still going to be there. And if you are on the low cost scheme, let alone something new that might come out, if there is some sort of new cost scheme agreement with the Council on Medical Schemes, those patients are just not going to be able to get care. And they will be dependent again on what is available in the public sector.
So Andy, I want to talk about something else, because I know we're talking about medicine selection going from EML to the National Health Formulary and so forth. But I think that there was another point about access that was raised that would impact also on the private sector, Fatima. And it's about this transition arrangement between sort of going from what we have now to an NHI that's fully implemented. And it's like, what do the medical schemes do? But more importantly, it's about the providers that have to be then selected and registered and done with the scheme, because it's different layers now. And I think I want to bring Sham in as well, because you have somebody like the South African Pharmacy Council accrediting pharmacies and regulating them. Under the NHI bill, you have the Office of Healthcare Standards that have to then accredit them. And there's different steps in this. And then now you've got medical schemes that have sometimes designated service providers. So there's all of this still that needs to be unpacked. And I think that Shah may have mentioned something in the chat about independent pharmacists making a submission, and I'd like to learn more about what he said as solutions. But you want to respond to that first, Andy, and then Inez?
Yeah, so one of the most confusing pieces in the bill is about those accredited service providers, because there are two sets of structures created: the district health management offices, which are a national government component, and then the contracting units for primary health care. And that's the most confusing. You can understand the district office. I don't like the fact that the provinces are cut out of that, but the CUPs appear to be contracting with themselves because they're made up of the provider networks in an area. The second problem comes with the preference that is expressed for group practices. And there's already a commitment in the white paper to use capitation at the level of group practices. Those are incredibly difficult for us to set up in terms of existing laws around, for example, the ownership of pharmacies and the involvement of prescribers in the ownership of pharmacies. So I have real questions about how to arrange those group practices that are going to be accredited by OHSC, but also registered by their professional bodies, and then be enabled to get a contract from the state. In many parts of the country, there will be no other alternatives than to rely on existing public sector facilities that at present are not meeting OHSC standards. Thanks.
So before I go to Inez, Sham, in your chat, you had said you made a submission. Did you all address these issues of accreditation and involvement within these NIH accredited provider issues?
Yeah, thanks, Fatima, and good afternoon, everyone. We certainly did, and I think there's multiple clauses that we've addressed in terms of these issues. And as you can see, Pharmacy Council, just to regulate a pharmacy with all the various issues, the institution themselves, to keep counsel in place, pays something like 15,000-20,000 rand a year towards counsel to facilitate that process. Now you have a new Office of Standards that are coming in. Who pays for them? Is it government institution? And would they be examining the same type of protocols that council puts in place in terms of good pharmacy practice, for example? So we've raised that as a concern. Andy's come up with one of the big problems that we've had, which is the group practice. Now, if you look at the way the group practice models work in some of the countries that are more advanced in the NHI type delivery program, you'd see that they've had existing structures that have kind of merged over many years, but you've got an infrastructure that exists and services what Inez has presented to you as a really good functioning private sector outside of the pricing model, but we deliver a service. So what do we do with all those institutions? What about the millions of rands of investment that we've already have in these infrastructure that has been ignored in the NHI bill? So we raise that as a concern. Then in terms of the basket of services, of course, the big concern is this disparity between what we use in the private sector and what is being utilized in the private sector in terms of a essential medicine list, for example. How do you merge that and continue providing the services that we do? When NHI does come in, does it mean this new list as to all our patients that are existing, how quickly do they have to adapt to a new list? What happens to them with the current model of care that we've already introduced into the system?
Thanks, Sham. Inez, is there anything that you want to add to that? Because I think the other bit that you raised was about the actual reimbursement and being accountable for everything that's claimed for and spent.
Yeah, I think I largely agree with Andy and with Sham. I think it's just important in terms of that basic coverage when we are contracting with providers. You cannot just have cover in the private sector for only the most expensive products. It's just not sustainable in terms of a health insurance contribution for that, and have some things totally excluded by the private health from the private healthcare sector. That's my huge concern.
Well, that brings me to the next question, actually, then. It's because of the fact that, I think, Andy, you've also kind of highlighted it in your presentation, is that there's going to be different systems in place. And have we actually thought these things through? Because you're going to have the National Health Advisory Board. You're going to have the National Health Insurance, the formularies. But you're still going to have things that are not covered by there that might need insurance to be covered. And there's going to be a private sector that's going to deal with that, whether that's high expenses or other things that are not covered under NHI, we don't know at the moment. Then there's going to be a different pricing system that exists for NHI, like you said, not tender, not SEP, but because there's going to be services and medicines that need to be accessed outside of the formulary, there still needs to be a pricing committee and SEP. Do you still see a need also for an EML committee in the interim as well, or after NHI is implemented?
So if you look at the bill and the white paper, it looks like a replacement of, or using, at least on the public sector side, the existing structures becoming responsible for the new. So the essential medicines list somehow being one of the committees that informs the work of the Benefit Advisory Committee and the procurement unit. I don't think that has taken adequate consideration of the need to continue to do the work they're doing at the moment and how long that will continue. So there is almost an assumption in the design that the existing public sector facilities will move into NHI, and an assumption that what is existing in the private sector will somehow disappear. And I think that's a fundamental design flaw. Rather than saying everything in the country, not only at the level of providers, but also at the level of HTA, the level of computer systems, of reimbursement and claim systems, how can we bring those into NHI rather than discard them and try to replace them with something from scratch? That's a very difficult transitional process to unpack. And I think we've highlighted just selection and procurement and shown how we'll have 3 different systems for a while with the intent that they slowly become one. It's unclear what will be left behind. So there's, people always talk about the exotic or the optional cosmetic surgery, for example. How will that be delivered if it is somewhat private? And I think we've not decided, are we going to go in the very dispersed way of a French or a German health system, or are we going to try to model this after a more typical British or Australian system with a very small private sector looking after the elite? And being allowed to do that because it doesn't impact as much on the overall quality of the system. But it raises very important equity questions. And not only equity in the end, but equity during the transition. And I don't think those are adequately covered in any of the plans, let alone in the legislation.
And I also think I'm concerned about the fact that they haven't looked at what the NHS is undergoing at the moment in the UK and the kind of problems that they're seeing there, so that we don't have that happening within the South African system either. And it also is very concerning to me that some of the countries that are used as examples, like even New Zealand, restructuring the way they do their benefits and their access and so forth as well.
So I just wanted to come back to Fatima Hassan's point about Paxlovid. And that's a really good example. So we finally got a single exit price for Paxlovid. So we now know what the private sector price would be. And it's 13,500 Rand before dispensing fee per treatment course. The benefits that attach to that, we don't think are sufficiently robust at the moment. So I would not see that as a good buy. I don't see it as something that we really know is going to, for example, prevent or treat long COVID. And given the position that we're in at the moment with the virus, it's just not value for money. And that's the key question is there value in the product at that price? And then what is the budget impact going to look like if, heaven forbid, we get 10 or 20,000 new cases per day? Could we afford to do that, either in the private or the public sector? And I think it's quite instructive to realize that the manufacturer hasn't actually made any stock available. You can't buy any, even if you're willing to pay 13,500 Rand per box of tablets.
Thanks, Andy. Inez, I'm not too sure if there's anything you want to add.
Just that Discovery Health agrees with you, Andy, on Paxlovid. But yeah, I think Andy's sufficiently covered all the responses adequately. I'm in agreement with him.
I want to come back to what we've learned from COVID-19 in relation to what we can do as a public-private partnership. I mean, there was the vaccine rollout. People had to register online, find an appointment spot, get there. You know, that kind of system worked for a bit as well. But I don't know whether we're thinking, you know, that there was some relationship set up there to sort of use some of the lessons from COVID-19 to better think through the NHI issues.
So Fatima, let me quickly jump in on that one, because I was involved directly in making some of those selection recommendations. And we tried to make those recommendations for both the public and the private sector. But when it came to the pricing and the budget impact, it was predominantly the public sector that was built into our decision framework. The vaccines were different because of the very initial decision by the manufacturers only to sell to governments. Now, that immediately set the need for collaboration because government would be the only one buying and then had to distribute. I think it was positive that we learned to build systems that enabled people to get a vaccine dose at either the private or the public sector, and for two different funders to be billed for that. Now, Sham will tell you that there are problems in the way in which the private sector was reimbursed, but overall, we saw that it was possible to have one fund charging against two different sources of income and delivery being agnostic as to who eventually paid for you. So that is a positive lesson. What worries me is how quickly that unraveled. So it is almost impossible to find a COVID-19 vaccine dose in the private sector anymore. There are no places that still have stock. What is available is pretty much only available from the public sector. And many of the systems like the DATCOV system that tracked hospitalizations have in fact disappeared. And we can't see how many patients with COVID are presenting on any given day at the moment in the way that we were able to do even 6 months ago. So it shows the fragility of those public-private provisions. And remember that when it comes to admitting public sector patients into private hospitals, only one of the 9 provinces actually finally signed a contract for that, and no public sector patients were ever admitted to private hospitals, even in that individual province. Thanks.
Thanks, Andy. Before I go on to Sham, I think that's going to be one of the final things we're going to have to do because we're coming to time, and then I'll go to Fatima Hussain. But just to remind everyone that webinars in this, and we're discussing these issues and more issues as we progress through the technical workshops as well. Sham, I'll go over to you.
Yeah, I think from a positive point of view on the vaccine campaign, it was probably our best opportunity to deliver something that looked like what NHI could actually look like, because you had everyone in the marketplace participating, you had part of business coming in, but I think there were some really big red flag that then takes us to the questions around NHI. And the first is the issue of transparency, because all of that monies that were spent, the accountability for that, we've not seen a proper draft of how that was done. Then there was a whole lot of donor funding. You remember how healthcare workers, for example, was done through a donor system. But remember when the ministry put it together, there wasn't this donor system in place at that point. It was just brought in just so that the J&J vaccines could come in and be ratified through the Sisonke program. So all of those health workers were done through the system, but funding was allocated from Treasury. So there's no answers for that. Then the issue of other donor funding, there's massive organizations like the mining industry that decided they're doing their own staffing and including their families. So all of that becomes donor funding. So I think some transparency is required around what happened with all of that and how did it pan out from a accounting process. the issue of payment has not been resolved in the private sector. So nobody has seen the money yet. We've had pharmacies that are on the verge of closure. There's major debates taking place. And the reason why you're not having private pharmacies doing the work now is because it's clearly you can't trust government to actually deliver on the model that they presented. So that's a big question mark, and it talks to the NHI modeling again. Thanks, Fatima.
Thanks, Sham. Any last comments before I hand over to Fatima from Inez and Andy?
No, I
Nothing
think
more from me. I'm done. Thanks.
thanks,
Just
Fatima.
look forward to the next one. I see Bada's hand is up.
Yes, I saw that too as well. Inez, sorry, I'll go to you and then I'll go to Bada.
Sorry, just a parting comment. I mean, from an administrative perspective, the collaboration between public and private sector did work well. I can say from the private sector that we certainly did pay what we needed to pay, as was agreed. I will not comment on the actual price of the vaccines. Personally, I thought it was inefficient. And it is sad to hear from Sham that the payments have not gone to the respective providers, as was the regional agreement. I think that's just my closing comment on COVID.
Thanks. So that's what we come to about accountability and transparency. Bada?
Thanks, Fatima, and greetings to everyone. Sorry, I missed a great chunk of the discussion, and I'm hoping to be able to get in touch with Fatima Hassan so that I can have a good look at the 17 questions. And my participation today anyway was going to be more from a Johnny Nash kind of vintage. I have more questions than answers, and I'm really trying to get answers to a lot of questions. One of the issues I was wondering about is this discussion taking place within the spirit that we now accept the NHI bill as passed by Parliament, and we're trying to find our way through it and trying to sort of find another way of staying alive within the NHI as it has been passed. For instance, I would also want to know, is it the end of the health market inquiry's recommendations? Are they not going to have another impact on the way NHI is going to be implemented? These are questions that I don't think we have time for responding to today, but these are just overall questions that I was wondering about. And I would also think that it would have been a good thing for people from NDOH to be present so that they can hear questions and concerns that have been expressed. And finally, just a comment to Sham, in terms of OHSC doing the accreditation for pharmacies. When I served on the board of OHSC a few years ago, we discussed the possibilities of an MOU, OHSC approaching the Pharmacy Council for an MOU that would ensure that the Pharmacy Council, due to their expertise, would continue to do the accreditation of pharmacies in both the public and the private sectors. Thanks, Fatima.
Thanks, Bada. I'm putting it in the chat because I want to hand over to Fatima Hassan, but quickly just say that we agree to NHI as a concept, and we agree to equity, but we don't think that the bill in its current form has thought through everything and might actually create more inequity than address the concerns that it wants to address. Fatima, I'll leave you for the last word.
Thanks. Yeah, but I mean, when we set the webinar, we didn't think that the B bill would be out. So that just has happened in the last 72 hours. We still thought there'd be more time to try and influence policymakers. So now we're all going to have to engage on this new 60-page version of the B bill. But just a few quick comments. I think that Sham's comment about the reimbursement complexities and difficulties, I think is really significant and material, because the entire reimbursement model of the NHI, if that doesn't work or doesn't work effectively, I think COVID is showing you that it's having a direct impact on the ability of the public to access something that is considered important and to, to be able to access services. And if that is the reason why people can't get vaccines now, or boosted doses or bivalent vaccines, then that's a really serious indictment of the entire reimbursement model that was promised to be the precedent for NHI. So I think that's a real concern. And maybe some of us are going to have to document some of the positive, but also the negative lessons of the vaccine rollout. I mean, we were a great part of our work was doing that, but I think there's some new stories that we're hearing today for the first time, which are really critical. And that includes obviously the lack of transparency we've been working on, and the procurement. And a lot of research has been done that the EVDS system, the online registration system, was actually one of the greatest deterrents for poorer communities to be able to access the vaccine. So if we're going to have these electronic, appointment systems or access systems that may not actually work for NHI, and I think we have to give, quite a sober reflection on where it works. But mainly around procurement and the role of the pharmaceutical industry, just to let you all know that we will be arguing our case for the opening up of the COVID-19 vaccine contracts, which we hope will serve as a lesson for open procurement under the NHI at the end of July. So we've been waiting for a year for the court date, and we finally will be able to argue our case against the South African government, who were forced to sign non-disclosure agreements by these pharmaceutical companies, which I think will give us a lot of detail and information around this requirement that they would only supply to the state, that it was a single procurer and a supplier system. And that meant that nobody outside of the state were able to procure these vaccines, and the reasons for that, including indemnification or the other contractual terms and conditions. So we're trying to open the lid on the secrecy of the COVID-19 vaccines contract, but with a view to try to create some positive lessons for NHI procurement, which we also concerned may not have the levels of transparency that they should. So I think it's just a plea to find a way where we document the lessons of the vaccine rollout. Thanks.
Thanks, Fatima. Just in conclusion, for all of you to please keep an eye out for our next invitation. I think it's scheduled for around the 20th of June, but we'll confirm in the invite and the link that's going out, and that if you do have others that may be interested in the conversation, can offer solutions, can actually, talk about how we can make this work better, we'd be really interested also in hearing from all of them. Other than that, from behalf of the speakers, Health Justice Initiative, the University of KwaZulu-Natal Collaborating Center on Pharmaceutical Policy and Evidence-Based Practice, we'd like to thank you for joining us, and we hope to see you on the 30th of June.
Thank you,
Thank
Fatima,
you.
moderator.
Thanks, everyone.
Thank you, Ines.
Thank you.
Andy. Thank you,
Thanks,
everyone,
everyone.
for joining.
Bye.
Bye.
Thank you. Thanks. Bye.
Thank you. Bye.